All right, if everybody wants to come on in and take a seat, I think we'll be ready to get started. So for today, we have one of our newer faculty members, and thank you for presenting today. And for introduction, I'll turn it over to Dr. Hansen.
Good morning, everyone. It's my pleasure to introduce Dr. Claudio Díaz for this morning's Grand Rounds. Again, for those who don't know him yet, he's the newest arthroplasty faculty member, but somebody I consider an old friend. Our paths initially crossed about 15 years ago at the Rothman Institute when I was doing my clinical fellowship, and he was one of the most productive research fellows under Jay Parvizi. After he finished his clinical fellowship, he returned to his home country of Chile, where he had a very successful early career. He was the chairman of his Department of Orthopaedics. He was the president of the Chilean Hip Society, and he completed what I call the academic century, which is that he has 100 podium presentations over 7 countries. The situation presented itself for him to reach out to me for a job opportunity here at San Francisco, and I took him up on the offer. And today he'll be talking about the direct anterior total hip. We often say the hip replacement is the operation of the 20th century, so I'm excited to hear why the direct anterior operation is the operation of the 21st century. Thank you.
Thank you so much, Eric. And before I start, guys, I'd like to thank my partners. I'll start with Jeff, Derek, Stefano, Dr. Barber, Dr. Vale as well. And of course, Eric, it's been a pleasure to be part of this group and this family. So having said that, we're going to start. And I will start with a question. How many of you in the audience never participated as a resident in a direct anterior hip? Mm-hmm. So those are my disclosures, and probably the most relevant one is the fact that I was a paid consultant by the PU to introduce direct anterior approach in Latin America and that particular device for navigating the cup. My surgical disclosure is that I was trained by very good surgeons in different approaches, and I've used myself 6 different approaches to do total hips. I still do some of them. I think an approach is just a tool to provide good results to our patients. But I'd say that in my hands, whenever I see a patient with a good potential for fast recovery, and if I see an anatomy that is suitable in my hands for direct anterior, I'd rather do a direct anterior for them. The contents of this talk, we're going to talk about the growth and the market of DA, my little personal journey in the field, the anatomical basis and its variants, the acetabular component and the stability in direct anterior, the femoral component and the femoral fractures we sometimes face in direct anterior, wound complications and the relevance and the value, if is there any, behind the use of direct anterior approach. The growth on the market, as Dr. Hansen was saying, we have to keep this in perspective. Hutter was the first one to describe this technique back in 1871. He was a very famous German surgeon in his days. Dr. Keji and Light were the pioneers publishing the results of direct anterior approach in the year I was born. Interestingly, they described the results in core in 85 patients. The units of red blood cells that were transfused on average for those DA patients in those days were almost 2 units. And interestingly, the length of stay was 12 days. That's something to be considered. We face a revival of the approach in the 2010s, and it's been increasing in popularity. But the question is, why was it such a new phenomenon? How many of you were practicing orthopedics or were residents back in that year? The rest of the audience was probably in preschool, right? So Eric was mentioning this article, probably for the youngest one in the audience, you guys will not recognize the first or the last author in that paper. This is a Lancet publication. Dr. Roravec is a giant in orthopedics. Dr. Lemont is also a giant. One of them is English and the other is Canadian, and they describe very beautifully how total hip replacement was making its way to be claimed to be the operation of the century. And many surgeons thought that we got to a point where no more technology or introduction of technology was worth it, considering the pros and cons, the risk and benefits, and also the cost. So the question is, why introduce changes in the most successful operation in orthopedics thus far? And I found the answer myself in a very old article, 1965. And I like to thank my dear mentor, Dr. Rothman, because the first time I met him, he asked me, Claudio, what are the journals that you are reading on a current basis? And I said, Core, JBS, etc. And he said, this is not going to make any difference in your career. And he gave me one of his issues of the Harvard Business Review. And I will tell you down the road how that connected me to UCSF. So if you look at the product life cycle and you consider hip replacement as a product, back in 2007, we were very close to the end of the stage 3, meaning the maturity of the process. But when you look at the different strategies the industry has to make this stage 3 a longer and more profitable period, you see that introductions of different uses of this product has to be made. And in that sense, you can prolong the phase 3 and your cells will not get to the point where they decline. So this is just an observation that I made myself. I thought that among all the possible innovations, there was a surgical approach that could be reproducible, associated with theoretically better outcomes, and able to potentially create a market. This is another reasoning. If it fails, the manufacturers could not be blamed because it was a surgeon choice and an execution-related problem. And we saw all of a sudden that the industry was supporting a new surgical approach, but opposite to the previous experience with the 2-incision Berger's approach, DA was not new and it has a proved reproducibility. If you look at the year 2007 as a limit to evaluate the literature in DA, you will see that between 1980 and 2007, you will find only 22 articles in PubMed. But after that period to the current year, you will see a 52 times more scientific interest in this topic, which is relevant. This is something that connects me to UCSF. You can recognize Dr. Bosik's name in there. And for those of you who are old enough, you will remember that this was the first time ACAS published the annual survey that they do at the annual meeting. And they were describing the patterns in our practice. The most commonly used surgical approach for routine total hip was posterior, almost 2/3. And the rest of the approaches were a rarity, meaning, for instance, the direct anterior approach represented around 10% of the surgeons. So it was rare. But 12 years later, which is a very short period of time in the history of hip replacement, DA became the most utilized approach. It's over 56%. Posterior is still holding in there with 1/3 of the surgeons. And notably, this survey was the first time in the history of the poll in which DA was the most popular approach for total hip arthroplasty. This is something that I found over the internet. It's a report by this company. It's called the Market Research. They said that the DA market industry is projected to grow from 1 billion to 2.5 billion by the end of this decade. And the compound annual growth is almost 12%, which is a huge number. If you consider that introducing an approach can drive the market changes, most of the things that I'm going to be presenting will make sense to you at the end of the presentation. And I will share with you a personal journey and a vision. As Eric was telling you guys, when we met each other at the Rothman, not all surgeons did direct anterior approach. Only two of our mentors were the ones that taught us how to do this. And I had the opportunity to write that very relevant article in the literature of DA with Hosak, which is probably the most important mentor, the one that taught me all the things that I know about DA. And I want to quote that one because behind the introduction of direct anterior approach, there is a strong scientific validation like no other approach in history. It has tremendous rigorousness in dissemination, is the only approach that I know of that has a particular book to describe the techniques. Now they are publishing the second version. It's very recommendable for those of you who are interested in arthroplasty. And it also has a marketing side, which is very strong as well. In this survey from 5 years ago, you will see that almost a fifth of the surgeons who had web pages and were members of ACAS back then were mentioning DA as a feature in their practice to make a difference in the results of their patients. Unfortunately, this very same article says that most of those surgeons were not claiming scientific data to back their observations. And I also got my first award. It's an article in Spanish regarding the results of Dr. Hosak's patients. And before I did my first case, I did 7 cadaver labs with different companies, and you will see that all the major companies are included there because back in the day, it was sort of a push by the companies to all of us to learn this approach. And I actually participated in some debates against very famous surgeons from a very famous institution as well. And to my awareness, when we are describing why we use one thing or another in our practice, we are very good explaining it, but we are not that good defending it. So what we did with Dr. Parvisi here, we use a structured way to provide answers to our questions and a mathematical model to describe why VA was better in our hands than DL, which was the approach that he uses also back then. And we did an analysis, and finally we proved that at least in our hands, DA was providing more advantages. But I also like to claim this quote that you guys can read there. It's by the president of the French Hip and Knee Society. And the most important thing he says is that we have to protect the interest of our patients when we are introducing changes and not be driven by the changes that the industry wants us to make. So today, it is in my practice one of the tools to provide good results, but it's not the only approach I use. I do many cases through posterior approach and some of them to direct lateral still. And I will show you guys some videos in the presentation, and those are patients that I operated in Chile. These patients are 2 weeks after the surgery, no PT, and you can see that both approaches behave very similar. There's no very big difference when you do the approach well and you choose your patient well. What are the anatomical bases? And I quote my technique because nothing of what I do was actually developed by myself. You will always read that this is an intermuscular and internervous plane. This is retrieved from our webpage from the Orthoanatomical, and it says that DA utilizes a true internervous plane between the superior gluteal nerve and the femoral nerve. Superficially, this plane is between the tensor fasciae latae and the sartorius. In the deep plane is between the gluteus medius and the rectus femoris. And for those residents who are not familiar to this web page. I think it's a tremendous advance in residence education. So this is a clinical picture that I took myself for that article. In the OR, that is the ASIS. We went 3 centimeters distal and 3 centimeters lateral to do the approach in those days. So, sometimes you may see some modifications. This is the first plane. You will see the tensor fascia lata and the sartorius. You have to keep your incision in the perimysium laterally to the interval. Then I do digital dissection to expose the uterine interval. This is the way we expose the acetabulum. It's a very good visualization. You have to keep in mind that these patients are in the supine position. And this is the way we expose the femur. And to be honest with you, I think my technique is, if not 100% equal, is 95% similar to the approach that Dr. Hansen does. I will share with you a little video. I hope it will be valuable for you. I did it with a GoPro because at some point I felt like doing DA was like doing X Games. So this is the approach that we use. This is the only fancy tool that we use to elevate the pelvis of our patients. I use ChloraPrep. This is the supine position. For those of you who are taller than 6 feet, I think having a table that rises up enough, it's valuable. Otherwise, you will be operating with your spine hurting at the end of the case. That is the ASIS, 2 centimeters distal and lateral. I go with the incision. I know you guys, you can see that back in Chile, I had 2 assistants. So that makes a difference, at least in my vision. Most of the case we do here is just with 1 assistant, and we are fortunate enough to have technology to help us. I will describe that afterwards. So that's the perimysium of the TFL. We go digital dissection. We rely a lot on the design of the retractors. Probably one of the most important introductions is that you cannot do a DA with whatever retractor you think it's good. All of these retractors were developed to do a direct anterior approach. They are very curved. They have some particular features that I think are valuable. You can coagulate the vessels there. You will put the white cobra in the lower neck. As you can see, plenty of retractors. You remove the pericapsular fat. This is one of the critical parts. You develop an interval underneath the rectus to position your anterior retractor, and this is critical during the surgery because this is exactly the time during the surgery where you can get to the femoral artery or femoral nerve. And I say that I like to do it by myself until the fellows or the residents are completely prepared to do it. I remove the capsule. I put my retractors intra-articularly. And then we do a double neck osteotomy without dislocating the hip. I know some DA surgeons dislocate the hip, especially when they are using the table. I rather do 2 necks, the napkin ring neck cut. I remove the femoral head with a corkscrew on power. And that's the way it looks. I recut the neck because the lady was long. I open the medial capsular fold. That's the exposure of the acetabulum there. I remove the osteophytes. As you can see, it's not difficult for the surgeon. That's this exposure of the acetabulum, which is pretty good. The way I ream with a straight reamer, and I use a straight impactor as well for my cups when the patients are not obese. The acetabular component, you can safely do screws as well. That's a visualization of the acetabular component and the polyethylene. I do external rotation and adduction. Nowadays, Dr. Hansen and I both modified our techniques, and we are using the operating leg underneath the other one. That's the exposure of the femur. And as you see, two assistants are more helpful than just having one. There are variants of the approach, and you will see that some surgeons use regular table, some of them double prep the legs as Nogler description, some others use traction table, some of us do longitudinal incisions, some others do bikini incisions. It can be done in the lateral position as well, believe it or not. I saw Dr. Cloisi doing it in WashU. It can be fluoroscopically assisted or freehand. You can coagulate the vessels or keep the vessels as Dr. Parvisi does. I think he's the only one that does that. He's good enough to do it. And keeping versus extracting the anterior capsule is also a variant. And I think we can safely say that there are 57 possible combinations to perform DA. So it's a very broad term to include an operation. And I have seen it done in 17 minutes from the incision to the start closing, and that was Hosak. And I know Derek and Eric will remember those days. We always claim that this is a very minimal invasive approach, but sometimes we damage the TFL. And actually, this is the only approach that has a scale to describe how much you damage the TFL. It was validated, and you can see that as your BMI goes higher, the risk of damaging the TFL goes higher as well. Let's talk about the cup position, dislocations, and instability. Back in the day, those concepts were part of the same principle. Nowadays, we know that the safe zone of Lewinek is not as good as we thought 10 or 15 years ago, so it's a very new approach to this problem. But let's focus on DA. What the literature says. In France, they presented 1.5% of dislocations. In Japan, 0.9%. In the USA, 0.84%. But globally, and this is a very good article, using multiple techniques, 1.2% of dislocation, which is a reasonable result. Majority of the dislocations are anterior and happen in the immediate postoperative time. When we look at the results of the Rothman Institute, a very huge number of total hips, you will see that DA wasn't the best for stability. Direct lateral approach in the supine position, the way they used to do it back then, was safer. But look at the rate of femoral failure, meaning intraoperative or immediate postoperative fractures, and also critical subsidence that gives you an opportunity for revision in these patients. Take a look at DA. It's 3 times higher than posterior approach, even in the what I consider probably the best hands in the world. So that is something to be remembered. You're always have to balance the advantages and disadvantages of the things that you elect as the best approach. And that is something that, at least in my hands, makes me think that for some patients, I rather do a posterior approach. Take a look at this reference here, the satisfactory cup positioning, meaning that we're positioning the cup in the safe zone. On the right side, you will see a Frederick Bettner JOA article that says that if you're using a fluoro, 100% of the time, he was getting the cup in the perfect safe zone. And to my awareness, that is the only article in the history of total hip that, without using advanced technology, meaning navigation or robotics, someone is able to produce 100% accuracy in their cup positioning. It is interesting. The rest of us are about 90 to 85% of the time. When you're doing freehand DA, there is a tendency to antevert the cup. With fluoroscopic guidance, they said that anteversion is better than in posterior approach. And actually, Fred Bedner has a formula to correct the anteversion in the fluoro. This study that compared the safe zone result of our cup positioning using or not using the fluoro, they said that almost 20% of the cups were more positioned in the safe zone using the fluoro. And there's also another thing that I realized very early in my career, and most of the VA surgeons will tell you as well, is when you're a right-handed surgeon, you will encounter differences in the anteversion of your cup, whether you're doing a right or left hip. And also you will find those differences in females versus males, which is interesting. So to my trail of thinking, this is the main advantage of the off-table, is that you can do a very good stability test. I start with external rotation and extension. I do flexion, and I like to go more than 90 degrees. Then I do internal rotation and external rotation as well. And I do now a figure of 4 that I think is useful for valuing the anterior stability of the cup. The Chuck test is also helpful. And that gives me the opportunity to tell safely to my patients that no precautions are required in DA. This is a lady that we did 6 weeks ago. This is the first post-op, and you can see that she's like actually moving the hip with no awareness of the risks, which is interesting. This is something that was first mentioned in the literature by Dr. Varry and Dr. Hansen. Correct me, guys, if I'm wrong, but you were the first one teaching us that patients with lumbar spinal fusions have a higher risk of dislocation. And since I read that article back then, I changed my practice a little bit. And this is an article from the Rothman Institute as well, Hosak, combining his patients with Alex Vaccaro, 2 rock stars in orthopedics. And they said that when you're operating in patients with a lumbar spinal fusion and you're doing the total hip in the supine position, the risk of dislocation using DA is the lowest in the literature. So it is something to be discussed with the patients. And nowadays I'm doing my spinal fusion patients in supine position. Let's talk about the femoral component. That is the stem I was trained with and thought it was the gold standard. After finishing fellowship, we always think that the things that we were trained with are the gold standard, but sometimes they are not. It is a morphometrically optimized single wedge stem. It has a double offset broach handle, and it has a learning curve of 20 cases in the regular table, which is pretty reasonable. And when you look at the results of Dr. Hosak, over 1,000 total hips, he had only 3 dislocations, 15 revisions, 4 for periprosthetic fractures, and only 1 for loosening. He had no intraoperative fractures and no perforations, and I think it is related to the way he used to prepare the femur. The stems were in neutral alignment in 98% of the cases, and the leg length discrepancy was completely irrelevant. But when you're used to work with surgeons like him, you feel like real life is going to be different, but then the literature and your own experience teach you how to be more humble. So things that we have seen changing over time is the use of a collar or the use of cemented stem through the A. I think those were potentially good answers. But this is probably one of the first articles that talk about the different results based on this type of stem you use. And you will see that the frequency, which the Corail, which is a compaction broach stem that gives you the option of a collar, was used in their practice, was massive. And they describe no aseptic loosing with that design, but it was higher with others. So then the single taper, the most popular design, the question was how it performs in DA. Greco from the JIS group in Ohio described that they had a higher risk of periprosthetic fracture with this particular stem. And also the single taper have a higher risk compared to a dual compaction broach design. And that opens a new door for innovation. This is a stem that was completely designed by DA surgeons. It is a triple taper. It has a very singular broach. It is a hybrid broach that gives you the opportunity to make compaction of the bone in the AP diameter and extraction in the mediolateral. It has an optional reamer for the diaphysis. It's intended to follow the calcar. It comes with a collar, and now the big 4 companies are producing stems that are very similar to this original design. And when you look at the data of the American Joint Registry in the blue line, you will see the rise in the use of this type of stem. Is a very steep curve, and nowadays is the most popular stem, even overcoming the use of the single taper that I was trained with. When you look at this analysis that I made based on the data of the American Joint Registry, the last publication 2023, you will see in green the vesting class, which is a stem that Dr. Hansen is using now, but it has no difference with the stem that the rest of us use for direct anterior approach. So they behave, when you look at the confidence intervals, they behave the same during the first year. But after 5 years, we have no data for the stem that was the best in class recently introduced, but we do have data for the Actis, the one that the rest of us use, and is the best in class. So interestingly, a stem that was produced to be used in direct anterior approach became the #1 stem in the US and the best in class, at least the design, during the very first year and after 5 years. That is interesting. So the stem design matters. And this is a very good article that I recommend to the residents and fellows. Keith Veren, who is a master surgeon in DA, he said that single wedge taper designs appear to have the higher rate of periprosthetic fractures. The proximal feed and field stems, like the triple taper, have a lower risk of periprosthetic fracture, and the addition of a collar in cementless fixation probably reduces the risk of periprosthetic fracture. But as we were discussing in Napa last weekend, we have no complete support to say that a collar is actually the answer and not the broach or the design. Let's talk about wound complications. DA surgeons, we think that this is a relevant topic in our discussion and during our decision making. You will see incisions that heals well, some others don't look very well but are well healed. And you will see superficial infections or deep infections, and you will see severe complications as well. You will see reactions to the dressings, and you will see the final results in those patients who had complications. But the most important thing is, at the end of the case, sometimes you can say that what kind of patients will have issues with the wound and what kind will not. And we are working with our residents to create like a good project to try to predict who are the patients who will have poor results in terms of wound healing. Multiple articles are describing this risk, and this is an interesting table that I created for you guys. So when DA was compared to posterolateral in regards of reoperations due to wound-related problems, you will see that the literature suggests that the risk is significantly higher, at least in the very first paper. It was like 7 times more frequent to have wound-related problems with DA compared to posterolateral, but the other article says that it's equal. At least in my hands, in my humble hands, I think whenever I see patients who have some sort of risk factor for wound healing, I prefer to do a posterior approach. And this was evaluated as well by these surgeons from New York City, and they found that the risk of wound complications and reoperations was actually related to the BMI of the patients. So they look for the complications in the higher risk patients. They describe that if your patient is over 40 in terms of BMI, they're going to have issues, reoperations, and they said that the cutoff point to avoid any wound complications was a BMI of 28 in their practice. Is something that I value a lot, and sometimes I use it for my decision making. But also, there's other articles talking about revisions due to periprosthetic joint infection, dehiscence, reoperations for dehiscency, reoperations by any cause, and total number of complications. And you will see that including direct anterior approach and the posterior approach, you will face wound complications if your patient's BMI is over 35, no matter what approach you use. But classifying those obese patients in DA and posterolateral, you will see that the benefit of doing DA diluted. Take a look at that rate of complications in patients whose BMI is over 35, whether you go DA or posterior approach. And the same thing with the reoperations due to wound complications. Both were significant in terms of the comparison. So again, surgeons directed innovation. This is a sort of modification that you can do for your direct anterior approach. Is actually not new because it was described 10 years ago by Michael Lennig from Switzerland. That is the original approach that we learned at Rothman that most of us use. And this is the so-called bikini incision, which is situated 1 centimeter distal and parallel to the flexion crease. It is centered over the axis of the TFL, and it is oriented distal and lateral to the ASIS. 1/3 of the incision comes medial to the ASIS. The rest 2/3 goes lateral. But the one that is medial, to avoid risks, you also do a superficial dissection. And you will see that the delayed wound healing, comparing all Hosak's patients with the conventional approach versus the bikini, were about the same. This difference was not significant. But when they divide the patients, whether or not they were obese, and as at the very top you can see patients whose BMI is 30, you will see that there is, the arrows show you difference in terms of the length of the surgery. You can say that 7 minutes, it's not a big difference, but according to Dr. Hosak's mindset, 6 minutes in 10 patients means an hour, so that is significant in his practice. And you will see that delayed wound healing as well was less frequent when you were using bikini incision. So it seems to be a reasonable alternative. And as I mentioned, it was described 10 years ago by a very famous Swiss surgeon. And this is the way I'm doing my bikini incisions as well. So wound problems in DA seems to be related to the obesity, which amplifies the adverse effects that we sometimes see in DA. And the bikini incision might be reasonable for obese patients undergoing direct anterior. Another topic that I want to cover is is there any value behind the introduction of direct anterior approach? And the question we should ask ourselves is, does DA offers any advantage over the other approaches for the surgery we do? And if we look at meta-analysis and comparisons between DA and all other approaches enclosing one group, you will see that in this particular publication, DA has better Harris Hip score and WOMAC only at 6 weeks, less pain at postoperative day 1, less analgesia, and smaller incisions. And I want to ask you guys, how many of you consider in your own practice those results to be relevant in the overall picture of a total hip? Probably very few. DA had more complications. It wasn't statistically significant, and the surgery was 7 minutes longer. This second article compares DA to posterolateral. With DA, you have more patients that can walk unlimited distance and stairs without assistance. It was significantly different. But you pay a price for this. They have more intraoperative fractures and more lateral cutaneous femoral nerve neuropraxia, which has been demonstrated to be not a deterrent in the long term, but something that concerns the patients in the very first 6 months. DAA has a shorter length of stay as well. The third one I'm going to include is direct anterior versus anterolateral, 5 articles, less pain at 6 weeks, better walk parameters, both were significant, but they have the same length of stay, complications, and transfusions. So it seems like all the advantages we were seeing were not actually real advantages. And this is a very good article recently published in the JAMA network of journals. You will see that this is a network meta-analysis comparing 8 different approaches. In green, you will see those who have definitely better results than PA. And the others conclude that there is moderate to high certainty evidence indicating that compared to posterior approach, all surgical approach except DL were associated with similar improvements in hip score, but longer operation time, meaning that still we have excellent alternative for all our patients. And in the overall picture, just an approach will not make a huge difference. And when I mentioned, guys, that I had a connection with UCSF back then, parallel to Eric and parallel to Derek and Stefano, who were good friends of mine since I started my career, I came to this classic article by Dr. Bosick. For those residents who haven't read it, I highly recommended it. And using that concept that I learned from him, the question is, functionally, DA does not offer relevant advantages over the other approach. We know that. So, but we have to ask ourselves, and what about the denominator in the value equation, meaning the cost? And I will share with you some interesting articles. This one looked for the cost during the very first 90 days after the surgery, and you will see differences in the overall cost. It is significant, but the main difference was observed in the post-acute care, and the most relevant difference they found was the use of physical therapy, comparing direct anterior approach with other approaches. And you have to remember as well that the first time it was described that physical therapy was not required after hip replacement was for anteriorly based total hip approaches, which is something to be considered. This is another article only focusing on Medicare patients, and you will also see that comparing DA versus the control, which was a posterior approach here, you will see that the costs were favoring direct anterior approach as well in a significant way. And what happened in a socialized healthcare system like Canada, and this is the thing that we applied in Chile as well, you will see that DA is superior in terms of saving cost compared to direct lateral or posterior approach as well. So it seems like when we look at the denominator of the value equation, you will see difference in favor of DA, even though at the numerator, there are no differences. It's also been described that DA has a lower risk of revision, as you can see in that graphic comparing different approaches, and their number need to treat to avoid one revision is 100 patients. So the question is, if we reduce by 1% the risk of revision, is it really relevant for the system? And the answer is yes, it is. Because with 1% absolute reduction in the risk, Medicare could save around $700 million over a 10-year period, which is a very big number. And the cost effectiveness of DA depends on the volume of the surgeon. So this is a very interesting article. In the line, you will see the limit for being cost effective. And they said that in the blue the blue dots and the green dots represent different thresholds to be cost effective. One of them include the use of implants, and the other does not include the use of implants as part of the equation. And when a surgeon is performing more than 100 DA cases over a 6-year period, which is a very low volume, DA can be more cost effective than posterior approach. So it means like all of us in our practice are being cost effective by doing direct anterior approach. So let me do a couple of final observations. My mindset back in 1990, when I was 10 years old, was set by the media to imagine the future in this way. And the residents will laugh at this because they never saw something like this. And this is the way one of my mentors used to do total hips back in that year. 3 assistants, supine position, etc. And nowadays we can do DA with 1 surgeon, with no assistants. But among all the significant advances we have had during the last couple of decades, we have seen larger heads with virtually no clinically significant wear and osteolysis, the use of the highly cross-linked polyethylene, morphometrically optimized stems, fast recovery protocols, same calendar day discharge, high accuracy using different type of technologies and implant positioning. And my humble opinion is that an approach is only one of many things that surgeons have adopted to make total hip a constantly improving surgery. In conclusion, I would say that DA has extensive validation and diffusion. It is a safe and reproducible technique. Only during the very first weeks has better functional scores. It continues to advance with the improvement we see in total hips. It produces a lower risk of revisions and lower cost and probably higher value. Thank you so much.
Right, thank you.
Thank you.
Dr. Diaz, that was excellent, and welcome as well, and really appreciate you being here today. I think we have time for some questions and discussion. I'll start, Dr. Hans.
Thank you, Dr. Diaz, for that balanced perspective on the direct anterior approach. I have a question about the adoption of the direct anterior approach for surgeons who are not trained on it. Can you just give me your thoughts on how a surgeon who's in practice and using a posterior lateral approach would safely incorporate that approach in his or her patients?
I think there are 2 approaches for that question, Eric. I think the first one comes from the literature describing the curve, the learning curve we face. I think it's been described between 20 and 50 cases. So I think if you want to have a number in mind for those surgeons, that would be the range to have a lower level of complications. But I would say that as a joint surgeon, I don't like to introduce 2 changes at the same time, meaning that if you're used to do your total hips in the lateral position, it's really different to face the acetabulum in the supine position. So that's one thing that will be difficult for the surgeons, and the use of fluoroscopic guidance might be helpful if you're changing your acetabular preparation and positioning from the lateral to the supine position. The second one is the use of different stems in direct and posterior approach. You can use virtually any type of stem. I think in direct anterior approach, at least in my hands, I would choose stems that are not fit and fill, single or triple taper stems. And I say having good training in cadaver labs, visiting surgeons who do direct anterior approach in a large volume, and choosing wisely the very first cases you do, meaning with no technical difficulties related to the anatomy, meaning long necks, probably valgus, neck shaft angle, and non-obese patients will make your transition a little easier.
Dr. Diaz, I echo Dr. Hansen's gratitude for a balanced talk. You didn't try to sell us too hard. But in the pediatric world, the anterior approach to the hip is front and center. We do all the time. I mean, it's sort of why the approach was introduced. Smith-Peterson spent a lot of time talking about doing the anterior approach for hip dysplasia. But when we've done anterior approaches in the older patients, so in the 6-month-old or the 2-year-old, it doesn't seem to matter. But when we've gone back in the older patients, and like today, Dr. Zhang and I are going to operate on a young adult with hip dysplasia, it's very scarring. Do you have any thoughts on that, how we can reduce that? It may be that yours is so limited, but we've gone back on, let's say, a Bernese osteotomy. The front of the hip is just all scarred in, no matter how careful we are. Any thoughts on that?
I have no data to support what I'm going to tell you, but this is just my observation. I think the Smith-Peterson approach, as everybody knows, is more medial. You're using a different interval. Sometimes you are retracting the rectus more aggressively. Some surgeons actually release the rectus. And based on my experience with high energy femoral neck fractures, in which I have used both approaches, the Smith-Peterson and the Hutter, I would say that the Smith-Peterson gives you a better visualization where you want to do hip preservation. I'm not aware of any studies comparing VA doing the regular Smith-P interval approach versus the Hutter, but I would say that probably working more close to the rectus will make your life more difficult. And also you have to remember that many of us resect the capsule when we're doing direct anterior approach. Probably the capsule has something to do with it as well. But we've seen also that after doing total hips in patients with a previous PAO, at least in my hands, I try to use a posterior approach because I know doing it with probably the same incision or a Hutter approach will be a lot more difficult, at least in my hands.
Thank you very much for your talk. I'm struck by how within a very short time, there's been a rapid development of technique and technology for this operation. This is in contrast to one of the operations that I do, which is total elbow replacement, where we have very rudimentary implants, rudimentary techniques, a smaller patient market, and which feeds into itself, where we have very select indications. I'm curious, as a student of kind of history of total hip and direct anterior approach, are there factors that maybe spurred rapid development of this procedure? You know, that maybe it's something that's coming for upper extremity surgeons, or is this, or can you identify anything that kind of can give us hope?
No, I would say that based on my description, I think the industry has a lot to do, sort of driving us in terms of where we are going to go. Probably the combination of efforts between surgeons and the industry can make a difference, but in all honesty, I don't think I have a good answer for that question.
Hey, Claudio, welcome. Very good presentation, and thanks for sharing your experience. I have a question about implant design. The way I look at it, design is that if the bone shape hasn't changed, why are we actually changing the design of implant? Is it your starting point that's different? Your angle approach is different? If that's the case, would that change your outcomes if you change your implant design? Because these are newer design. The result you showed actually from like 10 years or like the 5-year data was actually probably from the older design. What are your thoughts about implant design and approach. For me, it's kind of conceptualized. Why do we vary implant when it's the same bone that we actually dealing with? Yeah, the shape of the bone didn't change. Yeah.
I think the industry, again, has a lot to do with this. And I think the input that we surgeons provide to the industry is also helpful. With that design that I was totally convinced that it was the best. Eric, Derek, and I know probably all the tricks with it, but many surgeons who were not trained to use those implants were facing complications, periprosthetic fractures, perforations. So I think the industry and surgeon collaboration is the reason why we are changing this. And probably the easiest way to look at the tendency on how these designs have an impact on our results is looking at the registry data. These type of designs have been introduced to the US market, but not everywhere else. So it would be interesting to see if in mature markets of DA, meaning Australia or England or Asia, when they are doing DA since we started again, but with the same implants, it would be interesting to see if their results are comparable to ours.
Thank you. I think results are always very important, especially when you look at changes in technique, changes in design. I think following the patient, I think, is important. So thank you. Yeah.
Dr. Diaz, congratulations on an excellent talk. And I just want to also give you a little more kudos. Dr. Hansen did also tell us already that of your skills. For those of you who don't know, Dr. Diaz is probably one of the leading surgeons in arthroplasty in Latin America, has been recognized amongst his peers down there as one of the leading voices. And I think he's going to contribute also as a bridge to Latin America for us in San Francisco. And I think I'm really looking forward to seeing that happen. I think you're the highest published arthroplasty surgeon in the entire Latin American continent, South American continent. Congratulations on that career trajectory. I'm so glad to have you here. Can you talk a little bit about the use of the direct anterior approach for revision surgery? Many people are popularizing it now, and I'm just curious what your thoughts are.
My disclosure with that, Stefano, is I have never done a revision through the A. I think it's a completely different scenario. The approach can be extensile. You can do, at least theoretically, a very good job in the acetabulum for revision, especially if you have compromise in the anterior wall or column. For the femur, the technique of an extensile approach has been described. Some surgeons do even ETOs, extended trochanteric osteotomies to the A. I have no personal experience, and what I've seen from my partners is whenever we're doing revisions, we choose posterior approach. I say probably 95% of the time. Out there are many surgeons who even run courses about revisions through the A, but to be honest with you, I don't think we have good data to support that all revisions should be done through direct anterior approach. And another question that arises from there is what happens if I'm doing a patient who had a complication through direct anterior approach? Should I do the revision with a concordant approach or a discordant approach? And the data we have now is the revision approach is safe as soon as the surgeon who is doing it is comfortable with the approach. So there's actually no difference if you change your approach for revision surgery.
Dr. Kuo?
So a quick comment on Dr. Ma's question. So the bone's the same, but you find, as someone very early in my learning curve for DA, you find that the soft tissues and your exposure is different. And these new stems are easier to insert around the soft tissues and around the forces that are pushing your hand in different directions.
I agree with that.
All right. I think we'll wrap up there right at 8 o'clock. So Dr. Diaz, thank you again.
Thank you guys. Thank you.